Namaste Vidya, Hamisha खुश हो बतिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. Today, we are going to discuss about altitude sickness, and in this, we are going to discuss about the disorders of high altitude sickness. The physiological effects of high altitude are significant. The proportion of oxygen, nitrogen, and carbon dioxide in the air do not change with the fall in pressure, but their partial pressure falls in proportion to barometric pressure. Oxygen tension within the pulmonary alveoli is further reduced at an altitude because the partial pressure of water vapor is related to the body temperature and not to the barometric pressure. The reduction in oxygen tension results in a fall in arterial oxygen saturation. This is the graph showing the change in the inspired oxygen tension and blood oxygen saturation at an altitude. The blue curve shows changes in the oxygen availability at the altitude, and the red curve shows typical resultant changes in the arterial oxygen saturation in a healthy person. Now, what are the illnesses at the high altitude? Ascent to altitudes up to 2500 meters or travel in a pressurized aircraft cabin is harmless to healthy people. Above 2500 meters, high altitude illnesses may occur in previously healthy people. Above 3500 meters, these becomes common. Sudden ascent to altitudes above 6000 meters result in decompression illness or even loss of consciousness. Acute mountain sickness or the AMS. Acute mountain sickness is a syndrome that is comprised principally of headache, together with fatigue, anorexia, nausea and vomiting, difficulty in sleeping or dizziness, ataxia, and peripheral edema may be present. Etiology of AMS is not fully understood, but it is thought that hypoxemia increases cerebral blood flow and hence the intracranial pressure. The symptoms occur within 6 to 12 hours of an ascent and vary in severity from trivial to completely incapacitating illness. The treatment of mild cases consists of rest and simple analgesia. The symptoms usually resolves after 1 to 3 days at a stable altitude, but may recur with further ascent. Occasionally, there is progression to cerebral edema. The persistent symptoms indicate the need to descend but may respond to acetazolamide and induces a metabolic acidosis and stimulates ventilation. Acetazolamide may also be used as prophylaxis if a rapid ascent is planned. High altitude cerebral edema, that is HACE. The cardinal symptoms are ataxia and altered consciousness. High altitude cerebral edema is rare but life-threatening and is usually preceded by acute mountain sickness. In addition to features of AMS, the patient suffers confusion, disorientation, visual disturbances, lethargy, and ultimately loss of consciousness. Papilledema and retinal hemorrhages are common, and focal neurological signs may be found. The treatment is directed at improving oxygenation. The descent is essential. Dexamethasone 8 mg immediately and 4 mg 4 times a day should be given. If descent is impossible, oxygen therapy in a portable pressurized bag may be helpful. Next, we come to high altitude pulmonary edema or HAPE. HAPE is a life-threatening condition that usually occurs in the first 4 days after ascent above 2,500 meters. Unlike HACE, HAPE may occur de novo without the preceding signs of ANS. All these things I have already discussed in the previous slide, so I need not to repeat again and again the full form. The symptoms of dry cough, exertional dyspnea, and extreme fatigue. Dry cough, exertional dyspnea, and extreme fatigue. And later on, the cough becomes wet and sputum becomes blood-stained. There is tachycardia and tachypnea that occurs at rest, and crepitations may often be heard in both the lungs. There may be profound hypoxemia, pulmonary hypertension, and radiological evidence of the diffuse alveolar edema. The reduced arterial oxygen saturation is not diagnostic, but it is a marker for disease progression. Treatment is directed at reversal of hypoxia. Immediate descent and oxygen administration. Nifedipine 20 mg 4 times a day. Oxygen therapy in a portable pressurized bag. Next, we come to chronic mountain sickness or the Monge's disease. Prolonged exposure to altitude and has been reported in residents of Colorado, South America, and Tibet. The patient presents with headache, poor concentration, and other signs of polycythemia. The hemoglobin concentration is high, that is greater than 200 grams per liter, and hematocrit is raised greater than 50%. The affected individuals are cyanosed and often have finger clubbing. Next, we have high altitude retinal haemorrhage. This occurs in over 30% of the trackers at 5,000 meters. The hemorrhages are usually asymptomatic and resolve spontaneously. The visual defects can occur with hemorrhage involving the macula, but there is no specific treatment. Next, we have venous thrombosis. This has been reported at the altitudes of greater than 6,000 meters. The risk factor includes dehydration, inactivity, and the cold. The use of oral contraceptive pills at high altitude should be considered carefully, as this is an additional risk factor. Last one is the refractory cough. A cough at high altitude is common and is usually benign. The etiology, it may be due to breathing dry, cold air, and increased mouth breathing with consequent dry oral mucosa. This may be indistinguishable from the early signs of high altitude pulmonary edema. So this was all about high altitude sickness. In the next lecture, we will be discussing about underwater sickness or the deep sea disease. This session was powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.